Good morning, everybody.
Thank you so much, sir.
Hi, a very good morning, everyone. We are on 21st of February 2026. We are live for yet another session of CMAAO International Weekly Meeting. And we have a very important topic today on the speech and communication. CMAAO warmly welcomes for International Weekly Meeting featuring Dr. Apurva Pauranik as an emeritus neurologist and educator. Dr. Pauranik is a DM Neurology, AIMS, and is the director for Pauranik Academic of Medical Educators and Emeritus Professor at MGM Medical College, Indore, with over 37 years of experience. A recipient of prestigious Charak Award, he's widely been recognized for his contributions, neurology education, public health awareness, and his research. We are talking about Aphasia and related disorder of speech and communication. Sir, over to you.
Good morning, everybody. Namaskar. I am Apoorva Pauranik from Indore, India. I retired as a professor from Mahatma Gandhi Memorial Medical College, Indore. And as a neurologist, my core area of interest and research and public service is aphasia. I will talk about aphasia, and it is a type of disease or disorder of speech and communication. So now I would like to share my screen. Is it visible, my screen? No?
No,
Not visible?
not visible.
Just a minute. हेमंत, ये मेरा स्क्रीन शेयर करना है, जूम का रहा, ये रहा, और यहाँ से शेयर दबाऊं तो कौन सा वाला दबाऊं? ये पूरा
ये नीचे वाला ग्रीन है ना, नीचे वाला ग्रीन, इसको आप ले यहाँ पे करें।
एक मिनट पहले पीपीटी
ये ग्रीन है शेयर वाला, यहाँ पे आप करें।
हाँ, ये इसको तो शेयर दबाता हूँ, पर अभी
देखे ना।
हाँ, ये दिख
Yes,
रहा है?
just make it.
Thank you.
या
वो कर दीजिए।
हाँ,
Perfect, sir.
right. So, why this subject of aphasia is important? Because it is common and it is a common chronic disabling condition. And long-term disability at society level, community level, is measured by a metric known as DALY, Disability Adjusted Life Years. So, on that matrix, aphasia ranks unfortunately very high. And think about the type of life without speech and language. Just imagine the plight of the person and the family. The irony is that a lot can be done with good scientific evidence, but sadly, there is a huge treatment gap. That's why this subject is important today, and I'm so grateful for getting this opportunity. Primarily, assessment of aphasia and therapy is responsibility of SLP, speech language pathologists. But the role of internists and general physician is crucial in diagnosis, in therapy, rehabilitation, advocacy, education, and research, every aspect. The scope of aphasia ranges very widely. It can be, in terms of severity, it can be mild, subtle, to very severe. In the neurological terms, it can be expressive aphasia on the motor domain. It could be afferent or difficulty in comprehension at sensory domain. And the modalities which are affected in aphasia can be verbal, that means speaking and listening, can be written, which means reading and writing, and even sign language in deaf mute people. The modality affected can also be purely articulation, while the language may remain normal, but if only articulation is affected, only pronunciation is affected, we call it dysarthria. So dysarthria alone can occur, aphasia alone can occur, and the two can occur together. The scope of aphasia can also be mapped onto the linguistic terminology. So when a speech and language communication of a person with aphasia is affected because of brain disease, we can map it on phonology, how the sound patterns are affected, semantics, how the vocabulary and lexicon and meaning of the words are affected, syntax, how the grammar of the sentence and paragraph is affected, discourse, how the communication and description as a monologue or a dialogue are affected. So these are all linguistic domains, all of them are affected in aphasia. And aphasia can also be associated almost always with some deficits in higher mental functions like apraxia, agnosia, amnesia, and dementia. So you can imagine what a wide scope of aphasia is. The disorders of speech, language, and communication are many. Number one, there are disorders of phonation, and we call them aphonia, no sound at all from the larynx level, or dysphonia, hoarseness of voice, something like that. These are usually local and non-neurogenic causes. Occasionally, neurological causes can be because of vocal cord paralysis, say the laryngeal nerve being damaged or the 10th nerve being damaged. That is disorders of phonation. At a higher level, there are disorders of articulation. That means all the muscles which are acting like a member of orchestra in articulation of various sounds in our language. If there is something wrong, either non-neurological or neurological, there can be dysarthria. And sometimes it is so severe there can be anarthria. The neurological causes for dysarthria may be related to muscles of articulation due to myositis. There might be neuromuscular junction problem like myasthenia gravis. So when a person with myasthenia gravis is getting fatigued and his muscles which are involved in articulation have become weaker in a diurnal variation manner, his articulation will be affected. It can be affected in neuropathy, for example, GB syndrome. And there can be central disorders in the brain, brainstem, cerebellum, basal ganglia. It could be vascular, it could be neoplastic. So dysarthria can occur from multiple levels, non-neurological level, muscle, neuromuscular junction, neuropathy, and brainstem, cerebellum, and other higher parts. So the disorders of speech, language, and communication, we have covered two parts, disorders of phonation and disorders of articulation. Now we come to disorders of fluency. These are not aphasia, this is different than aphasia. And they are usually developmental. They are usually seen in young age, children and adolescents, and they include stammering, stuttering, cluttering, and we are not going to talk about them today. Finally, what we are going to talk about today is disorders of language, and this includes aphasia, but it also includes alexia, dyslexia, and agraphia. We would be devoting most of the time on aphasia. Hence, I will just define the other three terms. Alexia means acquired defect in reading comprehension. Suppose I am perfectly normal and I can read many novels and many books very fluently. But if something happens to my reading parts of the brain, it would be Kala Akshar Bhans Barabar for me. I won't be able to decipher. It would be the English and the Hindi scripts will appear Chinese for me. That is an acquired disorder of reading, alexia. If same thing happens right from the beginning in the childhood as a developmental defect, it is called dyslexia and it is a type of learning disability. And you all will remember the famous movie in Hindi, Tare Zami Par. The boy, the hero in that movie was suffering from dyslexia. And agraphia means You can speak very well, but you have difficulty in writing, again because of brain, not because of motor paralysis in the right hand, but because of the writing center in the brain is not able to give the commands to the writing hand. So these are the disorders of language. I will repeat: disorders of phonation, disorders of articulation, disorders of fluency, disorders of language, and today we are going to talk only about aphasia. A bit of anatomy. To understand the organization of language function in brain, think of three anatomical axes: Rolandic, Sylvian, and horizontal. Now, this picture, you see the line here, this is passing through the central sulcus or Rolandic sulcus. This is one plane, and there are areas anterior to this and there are areas posterior to this. So the part which are anterior, they include the area for Broca's area and supplementary motor area. And if there are lesions here, we will mainly get non-fluent aphasia. The parts posterior, they include the Wernicke's area and the angular gyrus and supramarginal gyrus. And if there are lesions here, we will get mainly fluent type aphasia, for example, Wernicke's aphasia. This is one anatomical axis. The second anatomical axis is Sylvian. This lateral sulcus is also called Sylvian sulcus. And most of the speech areas are present in this. Now, this circle around the sylvias, perisylvian we call it. It includes Broca, Wernicke, angular, and the arcuate fasciculus which are joining the Wernicke's to the Broca's area. So, if there are any lesion inside the sulcus, there will be severe aphasia. However, there are some areas which are outside this circle: the supplementary motor area, the supramarginal gyrus. So if any lesion occur outside this area, aphasia will be mild, and particularly the repetition function would be preserved. So that was the second anatomical axis. And the third anatomical axis is the horizontal section of the brain. And here we can say the subcortical areas and the cortical areas. The quadrangle here is pointing out to basal ganglia, thalamus, internal capsule. So there can be subcortical structures which can lead to aphasia. Usually, aphasia due to subcortical structures is relatively mild and it rapidly recovers. It has its own clinical constellation, its own clinical feature about which we will not go in detail. So we remember this is the traditional 150-year-old, right from the days of Paul Broca and Karl Wernicke. This anatomy has been taught to many generations of neurologists. What is new is that a new model, which is known as a dual stream model of spoken language. This is the left hemispheric view. And you see, again, we are paying attention to Sylvian fissure and the middle cerebral artery. There is a dorsal pathway and there is a ventral pathway. The ventral pathway is beneath the Sylvian fissure, and the dorsal pathway is in the dorsolateral part involving the parietal lobe. So there is a dorsal stream, there is a ventral stream. The ventral stream is concerned with what, and the dorsal stream is concerned with where. And the language is described nowadays in anatomical terms using these functional networks. And the 200-year-old debate whether the language function is strictly localized in one area or it is widely distributed all over the brain, this debate had been going on. Now we know that it is a combination of both. There are elements of localization and there are also elements of generalization, and this is all part of networks. Now we come to the clinical approach. When to suspect aphasia? You will suspect aphasia in every case of stroke because it occurs in 25 to 30% of survivors of stroke, mainly those involving the left hemisphere, mainly those involving the middle cerebral artery, and less commonly those involving anterior and posterior cerebral artery. You will also suspect aphasia after traumatic brain injury. In every case of dementia, whether it is Alzheimer's or frontotemporal, but more specifically frontotemporal dementia, that you will do the language assessment as you do for aphasia, because On all these dementias, many cognitive functions are affected. Most of them is memory, the other is behavior, but language is also an important cognitive function. So, if you are dealing with a patient with dementia and you want to do a real good examination and you want to write down real good notes, you will do assessment of language function apart from memory and other cognitive function in every case of dementia. And for that matter, you should do language assessment in any cerebral pathology. Before we go for the details of language assessment, we pay good attention to history taking, the mode of onset, the circumstances of onset, and all those things. We pay attention to handedness. About 90% of the people are right-hander and 10% are non-right-hander. And it has a bearing on the dominance of language function in the left hemisphere. Those who are right-hander, in them the language function is present in the left hemisphere 98%. Those who are left-hander, in them the language function is 50-50% in right and left hemisphere. So it just takes a couple of minutes. You should go beyond asking with what hand do you eat your food. That's one question. Second is how do you write. Problem is many people who are left-hander, they have been forced by their parent and teacher to take their meal with the right hand and to write with the right hand. Hence, you will ask 5-6 more questions about for example, how do you comb? How do you brush? How do you mop? How do you open the lock? So, handedness history should include a few more questions. You will also ask how many languages you know, because in India and in most of the other countries, people are multilingual, bilingual, and it has an effect on aphasia. You will inquire about education, occupation, other neurological and medical history, and the psychosocial background. The clinical examination of aphasia is time consuming and laborious, and it requires lot of training and experience. Primarily, it is the job of a speech language pathologist, but every physician, every internist, every neurologist, of course, should be doing a brief examination. It could be a screening examination, it could be a brief examination. Hence, all of you must learn what are the headings and subheadings in the clinical examination of aphasia, and I will devote some time about 5-10 minutes on the headings and subheadings of clinical examination. One is auditory comprehension, in which we ask the person to point to the objects and pictures, or we give them command and see whether he is able to obey our command, or we can narrate a discourse or a paragraph. We can say, please listen carefully, I am going to read a story, and then we ask questions. We also pay attention to articulation, that is pronunciation, and for which we ask them to sing or read out a paragraph, read out simple words. We ask them to repeat some words and sentences after us, and we pay attention to their pronunciation, articulation. Another most important part, most important subheading in the clinical examination of aphasia is fluency. How fluent a person is speaking. The examination starts right from the moment of what is your name, what are you suffering from. Our examination starts right from the beginning of history. So we pay attention to how fluently a person is speaking. We look whether he is speaking single words, or he is speaking in short sentences, or he is speaking in long sentences as I am speaking right now. That's a normal fluency. We pay attention to the grammaticality. The sentences which he or she is speaking, are they grammatically correct or wrong? Is he repeating some stereotyped utterances? Is she having word finding difficulty? She is halting, pausing, groping, tip of the tongue phenomena, or there are paraphasias, phonological and semantic. By paraphasia, we mean I wanted to say pen, but I say pencil. Oh, it's a related word, but not too far. Or I wanted to say watch, and I say phone. No, it is a paraphasia. It's a wrong word. Or I wanted to say this is an uncommon word, stapler, and I say blah, 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 blah. Now that's a neologism, a word which doesn't exist, or I will say circumlocution. What is this? The one which we bend around the neck or something like that for the party. This is circumlocution, beating around the bush. So all these aspects are part of assessment of fluency, the verbal expression. This is the most important observation. And for this, you must do the audio or video recording and replay it, and then ask your assistant to make comments about these. Third is repetition, in which we ask a person to repeat. Listen carefully. I am going to speak a few words. Are you ready? You will repeat after me. Initially, we will have high frequency words, then we go to low frequency words, then we go to naming, and I will show you the pictures and objects, how to name in the next few slides. The next heading assessment is reading and writing. I will not go into the details of reading assessment and writing assessment. Now, every physician says, I am too busy. I have no time for a detailed assessment. I will refer a patient to the speech language pathologist. That's okay. You have to refer. But before you refer and after the patient comes back to you from referral, it is duty of every physician to do some examination herself. Do brief screening test. I will show you the testing material which can be carried on your smartphone. Just use your smartphone. You can, if you have a couple of staff in your clinic or your department, you can train that staff or a volunteer in a brief screening assessment of speech and language function. So these are the tips for a busy internist. Now, what are the screening and brief tests? Some are standardized, but you can make your own non-standardized and non-validated tool. It is always better to follow a standard method. But in daily practice, in office practice, in bedside practice, we often resort to something uh, which is not standardized, which is, we can call it ad hoc. So ad hoc is certainly not good, but occasionally or often we fall back to ad hoc testing. No, not too bad. So there is an Indian adaptation of franchise aphasia screening tool. So take a picture of this slide, go for the Google, PubMed, Google Scholar, and search for this publication in Annals of Indian Academy of Neurology for this Indian adaptation. Something related to it was developed by me, known as HACCP, Hindi Aphasia Screening Indoor Test. Again, take a picture of this slide and this QR code to go to this test. And what do we do? Or take many pictures. One of the beauty or one of the important part of aphasia examination is we want the patient to give us a good sample of verbal speech. Now, many patients are very poor. Even healthy people are very poor. If you ask him, how did you do today? Some are very descriptive and some are having speaking, even healthy people, normal people. So to make a person with aphasia speak a fairly good sample of speech, you have to encourage them. Even normal people cannot speak. So you need to have pictures. The one picture which I have shown here, all these pictures are standard pictures. This is from USA, but I have done a bit of Indianization. And what do we do with the patient? Hey, look here. See what is going on in this picture. Can you describe it to me? And the person will describe with lot of effort, lot of labor. He would be missing many things. He would be using wrong words. And all this has to be video recorded. And then we replay and see where the person was making mistakes. And this picture, we call it Kalidas picture. And we ask him, hey, describe what's going on here and what will happen. Hey, look at this picture. The lady with an umbrella. What happens to her in the wind with the rain? And look at this picture. The lady with a purse and a thief is coming. And how the good Samaritan helps retrieve the. Now, the person should be able to describe this story. So, picture description, story description are very, very important. It just takes 2 minutes. but you get a good sample. And from that good sample, you are able to assess, is it a fluent aphasia? Is it a non-fluent aphasia? Are there any paraphasias? Are there word finding difficulties? How is the articulation? Unless you get a good sample of speech, your assessment of aphasia is incomplete and it just takes few minutes. It is worth doing it. Then these are some pictures. And I will show there are many pictures of nouns and there are many pictures of verbs. So these pictures have been developed by my artist at Indore and they are not randomly chosen. We pay attention to many criteria while choosing this picture, while making the artist to these pictures, and these are in different categories. There can be animals, there can be fruits, there can be clothing, there can be furnitures, many objects. Here I have mixed them, assorted, mixed. I can keep them into different semantic categories also, and all of them I carry on my smartphone, all these images, and simply my examination starts. Dear, look at this picture, and then my examination starts. So these are all nouns. Then action verbs. So these are pictures. Action verbs, doing something. Kriya Shabd, in Hindi we call them. More Kriya Shabd, more action verbs, more action verbs. So I will share all these things in as a part of our PowerPoint. And if the organizers of this meeting will keep this data on the website for a variable period of time, all of you will be able to download these pictures and keep them as a folder on your mobile phone. So there are so many action verbs. I have been working for many years with my artist to develop these pictures. Now I will tell you how these pictures are used. These pictures are used for auditory comprehension. How do I test for auditory comprehension? I will show these pictures. Dear friend, are you seeing these pictures on your screen? Or I have the printed cards. You can get printed cards in your office. Keep a shuffle of cards, tash ki gaddi, and remove one card at a time and put before the patient. Look, when I ask you, you have to put your finger. Where is rhinoceros? Now, if the person is able to put her finger on rhinoceros, it's a test of auditory comprehension. You will say, no, it is a test of knowledge. Yes, it is a test of knowledge also, but it is also a test of auditory comprehension. Then I will say, where are grapes? Santra kahan hai? Ananas kahan hai? Custard apple, where is custard apple? Where is tree? Where is auto? Put your finger on blouse. Put your finger on the person who is descending the stairs. Put your finger on the person who is closing the envelope. Put your finger on the person who is writing. Now, these are all tests of auditory comprehension. Or we say, listen carefully. I will read 4 sentences. The girl pushed the boy pushed the girl supported the boy, the boy supported the man, or something like that. So there are 4 sentences which are being read or which are being spoken to, and the person has to put this picture correlates to one of these 4 sentences, which can be spoken by me, which can be put on the card, and that can be read by the person. These are tests of comprehension. Listening comprehension, when I am reading it out. Reading comprehension, when the patient is reading these sentences and putting on the finger. So these are the ways of testing. Then these are the words for repetition. I will say, listen carefully. I will speak a list of words and you have to repeat after me. You can make your own list, but these lists are not randomly made. They are made based on the linguistic properties of a language, what we call as psycho-linguistic database of a language. Hindi also has a huge online repository of psycholinguistic database by IIT Kanpur. Search for it. Just put IIT Kanpur psycholinguistic database of Hindi and Professor Ark Verma. They have created this and you can have a big list of Hindi words. Then there are non-words. Very interesting. We ask the person to read or repeat with us certain words which are not existing in the native language of that person. I will say, I will ask, speak some word, repeat after me. Chena, Rika, Khako, Tuka, and I will ask him to salt also. Then I will go to the reading, I will go to the writing, I will not go into the details of reading and writing, and we will also go to other cognitive functions like memory, attention. I will not go into the details. We also pay attention to functional communication. Look, so far, whatever assessment I have talked is standardized, methodical, compartmentalized, do this, then do this, then do this. But when we communicate with people in day to day life, we don't communicate in nouns and verbs and sentences and matchings and etc. We communicate in a functional manner. So, people have devised many test batteries which measure communication in daily life, in which they pay attention to role playing, give and take, when to pause, कब रुकना, कब बोलना, कैसे सुनना, क्या जवाब देना, body language, to wait for your turn, to play the role, and an actual role playing in the day to life. A person whose speech assessment in a laboratory or in your OPD may show, oh, his score is very low, he is not performing well. But the family members say, sir, he is able to carry out his most of the communication. Why? Because when we live in a daily life, we have so many cues, we have so many prompts. In an office, in a testing lab, or you are constrained, you are being asked this and this and this. It's an artificial situation. That situation is necessary as a part of assessment, but it is equally important how that person is doing out there in the environment, in home, at the bank, at the railway station, in the superco store, in the mall. So in the daily life, how they are participating, people have developed very methodical assessment tools for functional communication. We pay attention to narrative discourse, how that person is talking and describing the story. We pay attention to quality of life. Every patient with aphasia has very sad, very unfortunate reduction in the quality of life, not only for himself, but also for the family members. And clinicians have devised very methodical scales, scoring proformas, how to assess the quality of life. I will not go into the details, but what I want you to know that when we deal with a person with aphasia and when our speech language pathologist is dealing or examining a patient with aphasia, we should at least know what she is doing. There is no boundary line between us and the SLP. We may not be doing. We may be too busy. It is the job of SLP. But I should know when I refer my patient to an SLP, I am expecting him to do this, so that when I send the patient with a referral letter, I will write down, dear friend, please pay attention to this. And when the patient comes back, I will pick up the phone and I will see the notes of the SLP. How detailed is his examination? I will be able to say, yeah, this fellow has done a good examination. He has paid attention to quality of life, to narrative discourse, to functional communication, to higher mental functions, to writing, to reading, so many things. I will be able to look at the uh, performance of an SLP. And if I think something is missing, I will pick up a phone and call a dear friend, please review the patient and look for this. If this communication between a clinician and an SLP is going, we will be serving the cause of our patient. Another part is bilingualism. So we should do the assessment of language function in more than one language. A person may be using the one language at home and family, and at the job and profession, he might be using English more often. So that assessment should be done in both the languages. You might be waiting till now that why I am not talking about types of aphasia and classification of aphasia, and why the words like Broca, Wernicke, global, transcortical, motor, conduction aphasia, anomic aphasia, ये सारे शब्द मैंने अभी तक क्यों नहीं बोले? I have not used these words. I am underplaying this classification of aphasia into the 8 categories. Of course, there can be more categories, but these are the 8 categories at the bottom. They are the well recognized aphasia syndromes. Why I am giving them lesser importance is that in the last 10-20 years, the aphasiologists all over the world have recognized that these classical syndromes of aphasia for last 200 years are practically not very useful. Okay, they are popular terms. We can still use them as a label, but we know when I say Broca's aphasia, I know Broca's aphasia is not tight jacket, straight jacket, watertight entity. There are 10 patients of Broca's aphasia. I have written the diagnosis Broca aphasia, Broca aphasia, Broca on 10. But if I go into the detail, all 10 will differ greatly. So there is a lot of overlap. So people say, please do not do the pigeonholing. Or as you remember in the post office, when the letters are being sorted, this letter will go to Calcutta, this will go to Delhi, this will go to London. So there are pigeonholes, and we call them sorters. So they sort the letters into different pigeonholes. Our patients with aphasia cannot be sorted into the pigeonholes of so many syndromes. It is better to describe the full profile. So you say his fluency is like this, his phrase length is like this, his auditory comprehension is so much at word level, at sentence level, his repetition is good at non-word level or not good at non-word level, his naming is good for action verbs but not for nouns, and his reading is defective at the English but not in Hindi. So you describe the whole thing in a paragraph instead of labeling. Wernicke is aphasia. That labeling is useless. So I am not going to teach you the clinical features of Wernicke's aphasia. I am not going to repeat the clinical features of Broca's aphasia. No fun, no use. Instead, when we describe the clinical picture of aphasia, we try to describe the defect in that given person on this diagram. These diagrams are known as box and arrow diagrams. Who makes these diagrams? Cognitive neuropsychologists. Who are cognitive neuropsychologists? These are the people who study the brain function not in terms of anatomy, not in terms of MRI scan, not in terms of middle cerebral artery, but they study the brain function in terms of hypothesis that in brain there is something called auditory input. They are not concerned with Wernicke's area. There is something called written input. So you are reading something. They are not concerned with the anatomy of reading. Then there is something called auditory analysis. There is something called input lexicon, that means the vocabulary of words. There is something called semantic system, which stores the meaning of all words. There is something called output lexicon, the vocabulary which will go out. And there is something called written output and spoken output. And there are some jumping arrows. So from auditory level, it can jump directly to the writing level. So if I ask you, hold your pen, and whatever I speak, you have to write. We call it dictation. So if I say, write down horse, so you listen with the horse, and with your pen, you will write down HORSE. So you have bypassed the semantic system. You may or may not remember the meaning of word horse, but you can still write it. So when we examine a patient with aphasia in great detail, we say, the localization of lesion in this patient is at semantic system. Oh, in this second patient, the lesion is at the red arrow, which is jumping from written letter to its sound pattern. This box is gone. This arrow is gone. So this is a different type of localization of lesion. We don't say the lesion is in the supramarginal gyrus, the lesion is in the inferior frontal gyrus on the left side. That's one way of anatomical localization. This is called functional localization, and this is important. And this is done by speech language pathologists because This localization on cognitive neuropsychological model dictates your therapy. What type of therapy exercises you will give to the patient depends on this localization. Again, I will not go into the details. A word about, I think, how many minutes we have more?
So we have, you can continue. We have another couple of minutes, but if we have a question answer, otherwise we have 10 minutes. So you can
Fine.
continue.
Okay. So a word about differential diagnosis of aphasia. Not to miss the diagnosis uh, when aphasia is present, but people miss it. For example, mild aphasia may be mistaken for normal variation. People with receptive aphasia who are not able to understand, they may go to an ENT fellow for hearing problem. People with anomia who are not able to name, they may be confused as amnesia. इनका तो memory खत्म हो गया. It is not memory, it is the naming. People with alexia who were reading perfectly well, but now they say, oh, I am not able to read. They go to an ophthalmologist for correction of their glasses. And people with jargon aphasia who are muttering neologisms and irrelevant words, they can go to a psychiatrist. People think he's having delirium or psychosis. And developmental disorders of speech in childhood are not aphasia. Developmental expression, stuttering are not aphasia. Hearing impairment and congenital deaf mutism is not aphasia. People who have pure dysarthria, only articulation is affected. For example, in motor neuron disease, when your muscles of articulation are effective, you have dysarthria. It is not aphasia. Aphasia is a disorder of language. It is not a disorder of articulation. So these are some of the other differential diagnoses. The therapeutic approaches are biological and behavioral. In biological, the success is not so good. Pharmacotherapy, many drugs have been tried, but the randomized control trials are giving just borderline evidence. There are non-invasive brain stimulation. We don't open the skull without invasion. We can stimulate the brain by magnet, and we can stimulate the brain by direct current applied to the scalp, and they are having some effect. The behavioral methods are the mainstay. So the biological methods are still not very strong, but what is done by our speech pathologist, that is the main thing. And again, they have two approaches which are not mutually exclusive, they are complementary to each other. One is impairment based. We address and work upon the specific deficit localized in that box and arrow model, not on the MRI. So SLP is not interested, they don't know how to read an MRI. They are able to localize the performance of their patient after 1 hour, 2 hours of detailed assessment. After 2 hours, they are able to say this patient is having problem with this box and this arrow, and this is called impairment based. And the other is functional. As I said, we don't pay attention to the arrow and box and all that. We say we will watch the patient in daily life, and we will what is called as life participation approach. So that both are complementary to each other. And mind you, it is the intensity. The total duration of therapy is spread over many weeks or months. And B, the same duration, say 50 hours. 50 hours of therapy is spread over many weeks or months, and 50 hours of therapy compressed in a lesser number of days. It is the B which is more successful. If you spread out your therapy, the results are not good. That's why we call it intensive language action therapy. For the sake of time, I will not go into this. Is somehow we have been doing at our clinic. So there are four. It's a type of group therapy. The patients are sitting, they are matching the cards. So someone is describing, the other fellow is listening. I'm having this card. Do you have the card or not? And this is a wonderful method. And at the end of 2 weeks, 2 hours per day, 14 days, their performance markedly improves. Intensively. I have also created a big book of more than 100 exercises called home-based exercises for people with aphasia as a part of speech language pathology. This is a table of content, and we give these exercises to caregivers of the patient, family members, So when the speech therapist is done, the patient cannot come every day because of logistic reasons, because of financial reasons. We give homework, and the caregivers of the patient are very important tools, are very important members of our team. We pay attention to rehabilitation, occupation therapy. So towards the end of my presentation, again, I'm holding on this page these three QR codes. One of them will take you to my website neurogyan.com and backslash aphasia. So aphasia related content is there. Another QR code will take you to my neurogyan.com YouTube uh, uh, lectures for patients. And third would take you to my YouTube channel and the playlists which are concerned with the speech. So please save these pictures. Please use them. The future is bright for people with aphasia. I have been very sad all these years because the treatment gap for patients with aphasia is huge. 99% of the people with aphasia do not get the treatment which they deserve for many reasons. However, I am optimistic. Better classification, semiological profiling, better understanding of neurobiology of language function, better design randomized controlled trials. To design a randomized controlled trial for a condition like aphasia is a challenge. But in last 10 decades, ingeniously designed therapeutic interventions with robust inferences have come. I am hopeful that advances in biological therapies, the pharmacology, the magnetic stimulation, the electrical stimulation will improve. And there is a paradigm shift in information technology and artificial intelligence, which will increase the reach of therapy with the help of social media, with the help of AI platforms, so that people will be able to do all those exercises on their mobile, at their home. So the constraint of going to a speech therapist will be reduced, and there are better psychosocial approaches. And I hope the awareness about and new avenues of rehabilitation will increase. Our patients with aphasia deserve more from us. So, this is my ahvan to all the listeners, all physicians. O physician, thou shalt become a bit of therapist, a bit of counselor, and a bit of educator yourself. You will never fail in referring a person with aphasia to a speech language pathologist, and not only that, you will never fail in seeking regular follow up from SLP. You will yourself keep updated about aphasia, and O physician, you will have faith in efficacy of speech language therapy. As they say, karat karat abhyas ke jadamati ho sujan. That's how the neuroplasticity works. If aerobic works for my biceps and deltoid, repeated speech therapy, we call it neurobics, it also works. Intensity matters. So this is the message we give to our patients. Thank you very much.
So good morning, doctor. Thank you so much for a wonderful presentation. I think it was a very detailed and insightful presentation. Now we open the floor for question answers. Anyone has a questions? Please, Dr. Bukhari, go ahead.
Thank you very much, Pauranik. It was really a beautiful lecture, also in Hindi and also in English. I enjoyed it thoroughly. Uh, can I ask the personal question? In India and Pakistan, is there any role of spiritual therapy?
Yes.
Yes. Thank you.
Spiritual therapy includes yoga, it includes meditation. Basically, these are relaxation techniques. They
Okay.
improve your self
Yes.
confidence, they improve your attention.
Yes. Yes.
Attention is very important for a
Very
person with
important.
aphasia.
Very
So, they will
important.
definitely help. I agree.
Very important.
Yes.
Thank you so much, sir. Thank you so much, sir.
So there's a very interesting question on Facebook. What is a role of speech exercise at the home play in recovery, and can technology there are a lot of mobile apps which are assisting in speech therapy. Does it really help?
Yes, I am glad that in last 5 years, many mobile apps have come up. Of course, in English and other European languages, they have been there for 3 decades or more. In India, they are coming up in last 5 years or so. So one is Avaz, and there is one more I will share later on. I am also in the process of making a couple of them. The slide, the brief video which I showed, the card exchange game, we are in the process of making a digital version of that so that people can log in at their home in different geographical locations at the same time under the supervision of a speech language pathologist. The home-based exercises which I have described, again, we are preparing in a digital version, but many more people are ahead of me, and all of them are good, but you should take advice of your speech language pathologist, how good they are.
Are there any medicines which help in speech therapy, speech recovery?
Many medicines I have been using, and in about 30 years back, the initial medicines which were used were bromocriptine, the dopamine agonist, later on levodopa. So dopamine agonists have been used, not good. Then serotonin reuptake inhibitor, SSRIs, they can enhance the acquisition of memory and consolidation of memory. They have been used. The third is CNS stimulants like modafinil or methylphenidate, all of them in very, very low doses. They can improve in consolidation and attention function before and after the speech therapy. Then the drugs which we have been using to delay the worsening of Alzheimer's dementia, that is dopa decarboxylase inhibitors, including uh, donepezil and the mementil and rivastigmine. They have been used in that. Yes,
30.
sorry.
Sorry.
Please repeat your question.
No, there was no question. I think somebody unmuted himself. Yeah.
Okay. So these are the rules of pharmacotherapy, limited rules.
Okay.
I will one word, just a minute. While the evidence base for the efficacy of speech language therapy is very robust, and it has been shown that if you combine speech language therapy along with pharmacotherapy, the results of speech language therapy improve further. Pharmacotherapy alone is not good, but pharmacotherapy as an add to speech language therapy improves.
Okay. How aphasia is different from memory loss and dementia?
Yes. So people with aphasia are not stupid people. They are not dumb people. They are intelligent. While people with dementia and memory loss are having real problem with their other cognitive functions. Language is cognitive, but if only language is affected in aphasia, their memory and their other cognitive functions, the visuospatial, they may be normal. So aphasia is only a disorder of language, while dementia is a disorder of memory, attention, visuospatial function, executive function. So many cognitive functions along with language are affected in dementia. So aphasia is a relatively pure disorder. Dementia is a much more widespread disorder, and language is a small part of dementia. Most important part of dementia is memory.
Do you have any other questions on the floor? Would you be concerned if somebody has started forgetting names or takes time to remember, and will that be linked to any of the problems here?
This is very common, even in young age. And I also suffer from that. And many people come to us with the worry that, am I going to develop Alzheimer's dementia? Can I do anything right now? So we do a brief assessment of their higher mental functions. There is something called MMSE, Mini Mental Status Examination. And there is another thing known as MOCA, Montreal Cognitive Assessment. MOCA is slightly better than MMSE, and every physician should have the MOCA or MMSE on her smartphone and develop a practice. So just do a brief assessment of MOCA or train someone in your office or staff to do the MOCA. I'm so busy with my patients, but I have a therapist, a speech therapist. She's trained and she gives me the result. Maximum marks are 30. And if the person is getting less than 25, I say, now you should go for a more detailed assessment. Fortunately, most of the patients, their worries are not serious. But it should not be lightly, it should not be laughed away. We should say you will do an examination and look for it. Don't worry. This is very common.
So I think, Doctor, we are at the end of the session. We are right on time. We have completed 1 hour of our education, I would say the public awareness session. If we do not have any other questions on the floor, we would like to say thank you and wrap up the session. So Dr. Pauranik, this was an excellent session. Can you give you give our audience a take-home message and what do you want to say as a very small take-home message?
So, dear friends, spread the word. Spread the word about aphasia amongst your colleagues, amongst your patients, their caregivers. Educate yourself. Read a bit more than whatever you have heard today. Go to the links which I have shared. So educate yourself, have faith, and as I said, do a bit of examination yourself, do a bit of therapy yourself, be optimistic that these things really make a difference in the quality of life of people suffering from aphasia. It is their right. They deserve this much from you, the physician.
So, with this note, we thank you, Dr. Pauranik, for this wonderful session. We would like to invite you again for a follow-up session in coming weeks. Till then, we would like to say goodbye to our viewers. Thank you so much for joining in.
Namaskar.
Thank you, Dr. Pauranik.
Right, sir. Thank you. It was a joy for me. I'm so happy.